I would like to thank again the organizers for the opportunity to talk to you about APECED or APS1, which is a syndrome that over the last few years we've seen a significant number of patients here at the NIH Clinical Center, and would like to share some of our experience and with you. So what does APECED stand for? It's Autoimmune Polyendocrinopathy, Candidiasis-Ectodermal Dystrophy, or APS1, or which stands for Autoimmune Polyglandular Syndrome Type 1. This is a rare autosomal recessive syndrome caused by mutations in the autoimmune regulator gene, although there are some dominant forms with incomplete penetrance that have also been reported by INTESTINE group in Norway. It's a very characteristic clinical presentation with a classic triad that involves a single infectious disease called mucocutaneous candidiasis, or CMC, hypoparathyroidism, and adrenal insufficiency. And having two out of these three represent really a clinical triad that any dyad among these three would give you a clinical diagnosis. Now, initially, this syndrome was reported from Scandinavian colleagues as primarily being an endocrinopathy, as you can appreciate here, with most of the diseases described being endocrine. And what I'll try to show you as we go through, that this is really a broadly immune dysregulatory disease that involves many organs far out from the endocrine tissues. And it's important to realize that and describe it as such, because only like that it is possible that young children that really suffer from manifestations that present to physicians can actually be recognized before they end up developing the full-blown endocrine components. So let's review a little bit what AIRE does. So AIRE is a protein expressed in the medullary thin epithelial cells, where it's critical to promote the expression of peripheral self-antigens and the negative selection of self-reactive T cells. So in the absence of AIRE, central tolerance is impaired, autoreactive T cells escape in the periphery, and they can infiltrate tissues and cause destructive autoimmunity. And we know that these CD4 T cells from the AIRE deficient mice are both sufficient and necessary, because adoptive transfer experiments and depletion experiments have really conclusively shown that in mice. Now, B cells in these individuals are also not normal, and they produce a variety of autoantibodies. And some of those have major diagnostic utility, as we'll mention in a bit. And very recently also have been recognized as a potential high-risk condition for severe COVID-19. So at the NIH, over the years, we've assembled a trans-NIH group of collaborators that span 10 different institutes. And we have brought a lot of patients here to evaluate them universally and uniformly, so that we can gain insights in all of their disease manifestations, with a goal to develop better diagnostics, better pathogenesis knowledge, and eventually treatment and prophylactic approaches for the syndrome. This is the wonderful team that I'm lucky to have in my lab, and they all are passionate and work hard on trying to understand this disease better and help our patients. So what do we do when the patients come at the NIH, and how we've learned about what I'm going to tell you in the next 15 minutes, is we do a very uniform clinical evaluation from all these subspecialties, regardless of whether the patient has the given manifestation. And that's how we've come to realize that certain disease manifestations are far more common than described. And the second part of my talk on the lung disease is going to really reflect this. All patients get the whole genome sequencing these days. We get a lot of studies from blood, urine, and stool to imaging, and then endoscopies when clinically indicated, but at the same time for additional research studies. We've enrolled over 160 patients in the last 7.5 years, which is still short of what we believe are the actual patients in the United States, but far more than I thought that we would when we started doing this in 2013. So what I'll try to do today is highlight a couple of important things we've learned through the years, and are very, very important for our community in primary immunodeficiency and immune dysregulation. That pertain to how we view clinical and diagnostic features in this disease relative to the earlier reports. So what was very obvious, and now actually has been slowly but steadily reproduced in other cohorts after our initial reports, is that there is a dramatic enrichment of non-endocrine diseases in this syndrome, and also a delay in developing the classic diagnostic criteria, which is a problem because if you only rely on those, you miss years of opportunities to make an early diagnosis, and we'll talk about why that's very important. So when we talk about enrichment of non-endocrine diseases, these patients can develop over 25 different manifestations, of which only 5 are endocrine. In our particular cohort in the United States, there is an enrichment in manifestations that include these 6 non-endocrine tissues: the small intestine, the liver, the stomach, the lung, the skin, and the salivary glands, in frequencies in these range that are far more common than previously thought. For some of those, that we were in the range of 5%, or for some of them not being reported beyond some case reports, as well as a variety of other manifestations that had not been reported so far. And when we look at whether these diagnostic criteria are actually useful to make an early diagnosis, the answer is not so much, because diagnosis with this dyad happens at the age of around 8 years, yet only 20% of the patients develop their first manifestations among these classic triad diseases. That means that 4 out of 5 children and their parents go from ER to ER and from doctor to doctor with other manifestations before they develop the classic criteria. And the median of those is 3, and many of them, as I'll show you, were not even in the radar of this being something that APECED patients develop. So this is one of those. We now call it APECED rush. It's an urticarial eruption that has a very characteristic neutrophilic dermatosis feature to it. These are MPO positive cells. And it can be down to the fat, so this is panniculitis, and it's a combination, as I said, of myeloid and lymphoid infiltration. It doesn't respond to antihistamines. And it is very, very important to recognize, because it's very often with mucosal candidiasis the first symptom or syndrome of this particular disease. So this is the youngest patient now we've diagnosed with APECED over the last few years on the basis of this urticarial eruption. This is a 10-month-old who has this characteristic, almost multiformer-like rash that we think that physicians should be aware of, and when they see in the context of candidiasis, always think of APECED for an earlier diagnosis. So when we look at all of the manifestations that happen early on, and we compare them with the classic triad, you see another triad that we've called adjunct with that rash, intestinal malabsorption, and enamel hypoplasia. Again, an early feature that can be seen by dentists when the kids go first to their dental appointments. That can happen early, as with the classic triad. And if we combine these into a hexad of the classic and the adjunct triad manifestations, and be aware of those as having 2 out of the 6 early diagnostic features, can actually make the diagnosis 4 or 5 years earlier, half the time compared to the classic triad. And in about half of the patients, people could be diagnosed, actually kids could be diagnosed before they end up developing adrenal crisis or hypocalcemic seizures, in some cases being fatal actually as the first manifestations as young kids of 2 or 3 years of age. We've now come to confirm this in separate data sets, including from European patients we've enrolled through the years. So this is not necessarily an anomaly of American APECED, but also is seen in patients we've seen from Europe, from non-Nordic countries, from the UK and mainland Europe. So I think it's important to realize that the spectrum of APECED is far broader than previously appreciated, that affected children are likely to be seen by a number of specialists, from dermatologists to allergists to immunologists to dentists to GI specialists and pulmonologists, not only by endocrinologists. And when they reach to be seen by endocrinologists is usually when they're about 7 or 8 years old, but have had disease and diseases for several years before. This has major implications for management, not only because, as I said, half of the patients could have had screening for adrenal and parathyroid problems, and as a result of that do not develop life-threatening crisis, but also because we believe that an earlier diagnosis, like in that 10-month-old that I showed you earlier, could actually lead to earlier prophylactic interventions which we're actually in preparation of developing here at the clinical center, so that we implement immunomodulation early on with the hopes to alter the natural history of the disease. Now, when you see these manifestations as a physician in these children, what do you do? So you need to sequence the AIRE gene, and then you need to look for autoantibodies against type 1 interference. So here is what we think is the prevalence of APECED in different parts of the world. Sardinia, Finland, and Persian populations appear to have higher. In the United States, with an estimated prevalence of about 1 to 100,000 to 300,000, we would expect that there are probably 1,000 to 3,000 patients with APECED in this country, and we've only seen 160 of them. So we have much more work to do. When we suspect this, and when you suspect it, what you need to do is to sequence the AIRE gene. There are some characteristic mutations that come with different cohorts. In the United States, it's typically compound heterozygous, although not always. And the 13 base pair deletion that is common in the UK is also the most common mutant allele. I mentioned autoantibodies against type 1 interference, which are actually very early on present. And in patients who you suspect that they might have APECED, testing for them, which we can easily do in my lab for anybody who is interested and wants to rule in or rule out this problem, is also important, because very recently with Jean-Laurent Casanova, we published a paper in JXMed showing that the presence of these autoantibodies is associated with severe COVID-19. The presence of these autoantibodies in the general population has also been associated with severe COVID-19. And as you see here, that has led to strategies in order to implement early vaccination in these patients, which is much needed for COVID-19. And the second part of my talk, I would like to talk about a disease manifestation that when we started enrolling patients, we were actually not very aware of its existence. The literature had case reports, that's autoimmune lung disease, and how we've come to realize how to effectively treat it and provide really the first proof of concept of an effective treatment for autoimmune disease in this syndrome in humans. So what happens through this uniform evaluation that included CT scans of the chest on every single patient who came at NIH, we realized that about 40% of patients actually have autoimmune pneumonitis, vast majority of which, actually over 90% of them, came to us with a diagnosis of asthma and bronchitis. So this is one example of a patient who was called as having asthma, and you can appreciate here this is interstitial lung disease. This is another patient that also we saw after several years of not proper diagnosis, and this is also autoimmune pneumonitis. When you don't treat this and autoimmune inflammation continues unabated, it can result in structural lung disease, which creates bronchiectasis, as you can see here in this milder version, and this is more intermediate severity version. And then when you continue unabated, you can develop severe bronchiectasis and structural lung disease that causes recurrent infections. That's when people start getting in trouble with hypoxemia requiring home oxygen, severe PFT abnormalities, and in some cases, death. So this is a 14-year-old that we saw in 2014. He started having cough at the age of 9 and died at the age of 14. So a few months after he saw us, he had, when we saw him, complete replacement of his lungs with bronchiectatic airways, as you can see here. This is a gentleman who we had at the NIH for over a year and a half, who had about 45 years of what he was told to have allergic bronchitis, but it was really autoimmune pneumonitis that caused bronchiectasis, MAC lesions that caused the bronchopulmonary fistula and empyema. He had to have right middle or lobectomies in order to remove those lesions and clear up the empyema. The progression, as I mentioned, from the 9 to 14 years, and in that older gentleman between the ages of 5 and 45 varies significantly. And a CT chest is imperative for every patient with APECED, even in those who don't have respiratory symptoms, because early on, about 10% of the patients with pneumonitis, we do not actually have apparent symptoms, as I'll show you in just a minute. So as we started realizing that this is a common entity, we wanted to understand the pathogenesis of this disease, so that then we not only tell the patients that you don't have asthma, you have pneumonitis, but also to offer treatment. In order to do that, we did bronchoscopies with biopsies in both patients with APECED as well as in healthy volunteers through a research protocol, as well as corroborating studies in mice to characterize this immunopathology with a very characteristic picture. So these patients have an enrichment of neutrophils that are activated, as shown here by a higher expression of CD66B and B558 in their airways. But deeper in the tissue, they don't have neutrophils. They have lymphocytic infiltrates, as you would expect, as for the autoimmune disease of this sort, that you have escape of autoreactive T cells. So you see here submucosally a lot of CD3 positive T cells, which are both CD4s and CD8s. And when you do transbronchial biopsies, what you see is the hallmark of the disease, which is bronchiolitis and peribronchiolitis, in some cases with hyperplasia and fibrosis. And here again, a lot of T cells, both CD4s and CD8s, but as opposed to the endobronchial biopsies, here deeper in the tissue, you also have B cell aggregates. So a significant infiltration by CD20 positive B cells. In order to understand whether the T and or the B cells drive the disease, went to mice that also have a similar phenotype with humans, this peribronchial infiltration of CD3 positive T and B220 positive B cells. And in mice, we can deplete T cells and B cells respectively by crossing with TCR alpha and IgHM knockout mice. What you can appreciate here is that an AIRE knockout autoimmune lung is restored back to normal when you remove the T cells that cause the damage, and partially restored when you remove the B cells. This led us to hypothesize that if we target those lymphocytes that cause the disease, we might actually put the patients in remission. And indeed, when we've now treated over a dozen of patients, and we published this first experience a couple of years ago in the first consecutive 5. All patients had resolution of cough and shortness of breath. They had improvement in their quality of life. Their radiographic abnormalities almost resolved, and pictures are more important than words. So this is a 9-year-old who also came here with a diagnosis of bronchitis, and she had this impressive nodular autoimmune lung disease. A month after treatment with Immuran and rituximab, her lungs are much improved. 6 months later, completely resolved coronal views that show exactly the same. And this is another patient. Actually, this is an asymptomatic at the time patient with significant ground glass opacities and bronchiectasis. So again, even asymptomatic patients should get a CT scan. Within a month, the disease gone. And this is another patient, a 30-year-old, who also came to us with a diagnosis of bronchitis, had autoimmune pneumonitis, and fancy 3D reconstructed images here. You can see within 1 and 6 months, the disease is also ameliorated, associated with improvement in clinical as well as pulmonary function tests and improvement in quality of life. Now, when you deal with a rare disease like APECED, you can learn things that can apply to more common diseases. So biology is complicated, but sometimes pathways that are turned on or dysregulated apply more broadly. So there is an entity called thymoma. These are malignant tumors of the thymus. And in some of these patients, there have been reports of poorly characterized lung disease. These thymoma patients actually have been shown to have secondary AIRE deficiency. And turns out when we characterize some of these patients here at NIH, we found that thymoma patients have autoimmune lung disease that looks very similar to APECED, with this peribronchial and bronchiolitis kind of picture with neutrophils in the airways and peribronchial T cells and B cell aggregates. And now we've treated the first 2 patients with Thymoma-Associated interstitial lung disease with the same kind of regimen that we've used for APECED pneumonitis. This is the first patient who got azathioprine, and his disease also, as you can see here, resolved. Another patient that we recently saw for a follow-up after a year of start of treatment also completely resolved. So lessons learned from rare diseases like APECED could be valuable for more common diseases like thymoma. We're now looking actually at Sjogren's-associated interstitial lung disease, as that also is an entity that causes bronchiolar inflammation. About 10% of Sjogren's people in this country. That would be about 300,000 to 400,000 individuals. And through a large cohort of Sjogren's patients here in NIDCR, we're actually in the beginnings of evaluating them the way we did it with APECED and seeing whether we develop a treatment protocol that includes the same therapeutics. I'm going to end with a quick snapshot of other major things that we're very interested in and what we study in these patients, mechanisms of susceptibility to Candida, GI disease pathogenesis, bone marrow problems that rarely these patients can get, genetics in some patients who don't have biallelic problems with AIRE. And as I mentioned earlier, we are very keen in developing prophylactic immunomodulatory strategies as well as mechanism-based therapies. And we've made significant progress to that, to the point that we're actually, by the fall, I think we'll have an IRB-approved clinical protocol to enroll patients using JAK inhibitors for treatment. So to end, we've come to realize that expanded diagnostic criteria that include that APECED rush that I showed you earlier, that is very common early on, and increased awareness among clinicians may have important implications in early recognition and improved patient outcomes. Lung autoimmunity is a common and devastating complication, mostly unrecognized, and responds to lymphocyte-targeted immunomodulation. I think understanding the pathogenesis of lung and other tissue autoimmunity in APECED, and I would posit in any uncommon primary immunodeficiency disorder or immune dysregulatory disorder, may have implication in other diseases and other syndromes that are far more common, as in the case here I showed you of thymoma, and as we are now exploring the setting of Sjogren's. And the future, I think, for APECED should get us to a mechanism-based treatment intervention for end-organ autoimmunity and early administration of targeted immunomodulation to avert the development of multi-organ autoimmunity in humans. We can do that in mice. We can completely abort the disease. And we are hopeful and aspiring to do that in humans. With that, I would like to thank you for your attention, and I'll be happy to answer any questions through an email exchange, as I'm not going to be able to have a live Q&A session for this particular talk today. Thank you very much again.